Welcome to demonstrating implementation excellence stream of SNOMED CT Expo 2022. My name is Yael Applbaum and I'm Customer Relations Executive and for Asia Pacific and Education Lead at SNOMED International. I will be moderating today's session. All questions will be answered at the conclusion of the presentation. Online attendees, please use the Q&A box to type your questions to the presenter. On-site attendees, please use the microphone here. And I'm now pleased to introduce Yael Applbaum from the Israel Ministry of Health, who will be presenting Israel's National Terminology Initiative, Challenges of Implementing SNOMED CT at a National Level.
So good afternoon, everyone. I hope you all enjoyed a nice lunch and came here to take a little nap, but a postprandial nap. Anyway, yes, I'm here to discuss our medical terminology initiative, but mostly I'm here to talk about the implementation of SNOMED CT, which is part of the initiative. And we're going to talk about the challenges and the fact that it's an international. Next slide. So I want to start my talk by presenting the aspects of the Israeli health system that pertain to the implementation of SNOMED CT. In Israel, there is a national health insurance law, so every resident is insured for health care through payment of monthly premiums to the National Insurance Institute. Everyone is covered with the comprehensive basket of services, and there are 4 providers that supply primary care and also pay for inpatient care for when it's needed. The system is mostly paperless. Every citizen has a medical file in one of these 4 EMRs in the primary care system. The EMR is part of the general health record that integrates all patient information, including laboratory, imaging, primary and secondary care, pharma purchases, the patient portal, and other administrative data. The EMR shares a minimal data set of important medical information with the EMR of hospitals only at point of care and only on demand. The transfer of information is realized by the Health Information Exchange System, which is called OFIC or ETAN. Until now, we have been using ICD-9 to code diagnoses and procedures. But as you know, this version of ICD has not been updated since 2011, and therefore institutions started creating ICD-based codes to fulfill their needs to document and to get reimbursement. So we have many new codes that we call local ICD-9 codes that unfortunately are not uniform across all systems. So as you see, the systems have to be able to properly document the patient encounter, but also to talk to each other and communicate. And that is where the decision to implement a new modern uniform terminology was born. Next slide. No, slide before. Okay, so when I was preparing this talk, my colleague Barbara was telling me that I was mixing up what the meaning of challenge and what's the meaning of a task. So I will tell you that I cut my talk down to talk just about challenges, things that I think will not be easy to implement. Next slide. So the first challenge is getting is getting everyone on board. Okay, we have a lot of stakeholders and we have to get them on board. Next slide, sorry. So I was debating where to put the emphasis in my talk, on the challenges or on the fact that the project is on a national level. So I decided to put in this presentation, I will try to emphasize what is the challenge, but also why the fact that it's a national project has special meaning to the challenges. So general challenges will be colored red, while national aspects will be colored blue. So why is this a challenge? So this is a challenge because implementing a new terminology is expensive, it's labor intensive, and even if individual organizations agree that the outcome is important, they often would rather not incur the expense or the effort. Why is it a problem on a national level? Is because this initiative is government controlled, and that always raises suspicion among people. On the other hand, it has to be government controlled in order to centrally to enforce the systems, to coordinate and to implement at the same time in order to be able to interact with each other. Next slide. So what are potential solutions? So first of all, we had to put in incentives into this program. So the financial, we have a financial incentive model in which hospitals and health funds will be provided with resources to make these changes. We have a coalition that helps us along because there are other communities that have their own personal interest to see us succeed, like the fire community and the interoperability staffs. Next slide. So our overall solution is basically sort of running a campaign of webinars, lectures, training sessions to demonstrate how SNOMED promotes better documentation capabilities and better analytics. And yes, prayers are part of our program as well. Our next challenge is introducing and managing changes both in the workflow and the technological changes. Next slide. So I'm not familiar with other countries, but in Israel, clinicians tend to be very conservative people that like routine. They're also in a shortage and they are overworked, and every extra task is viewed as a major burden. Also, the Physicians Professional Association, the Israeli Medical Association, is very powerful, and they have the potential to enhance resistance. So we want this project to make life easier for the clinicians and not harder. And we have to keep this in mind all the time. Also, the clinical coders are facing changes in their workflow and their job description, not only in the SNOMED implementation project, but also in the ICD-11 implementation project that is going to follow this one. So the transition also technologically, the transition has to be accomplished with minimal disruption to the healthcare system in order not to cause any harm to patients and no loss of income due to reimbursement tables that will be changed. And new interfaces have to be put in place in order to preserve the decision support systems that are there and the historical data. Next slide. So our possible solution to this challenge would be to identify an efficient search engine to be incorporated into every EMR to facilitate the selection of diagnoses and procedures in a way that will make, as I said, make the clinician's job very, very easy in a user-friendly, efficient, and precise manner. And although organizations can choose to use their own search engines, we felt that it would help to do all the legwork centrally and find the most ideal search engine and facilitate the creation of UIs to allow organizations to utilize it. We believe that a good search engine is the key to making the clinician's workflow easy and quick, and it's also a key to our success. Clinical coders will now redesign their workflow to accommodate the new terminologies. Next slide. And just like the search engine, that we need to have something that's user-friendly and good, we are also going to be using a central terminology manager that we are going to finance and maintain in the Ministry of Health. And we believe this is another key to making the transition easier. It's not only will allow users to take advantage of SNOMED's many features, but it will allow them to manage other independent processes in the hospital as well. It would allow the NRC a clean, structured path to distribute and update SNOMED editions, new mappings, creating subsets, and maintaining the Israeli extension and the EMR subset. In addition, we will have to address cybersecurity issues, different implementation approaches to allow full control of data security for every organization, even though we're using a central manager. Our next challenge is that we have multiple vendors of varying size, influence, and willingness to cooperate. One vendor serves 80% of the hospitals. That vendor has a record of slow response and slow innovation. And each hospital that uses this vendor negotiates separately with the vendor, and that each one has a different version, and that can also delay implementation. The remaining hospitals work with other vendors, or they use EMRs that were developed in-house. Primary care, as I said in the beginning, is supplied by 4 health funds that are supported by 3 different vendors. So what are our solutions? So we decided that we are going to negotiate and finance the implementation with the main vendor, the one solution that will be able to meet 80% of the users, regardless of what software version they're going to use. So the idea is we're aiming to minimize the amount of manipulation to the structure of the EMR and to maximize UIs, both to the terminology manager and to the search engine. Our next challenge is financing the initiative. This initiative is budgeted not by the Israeli Ministry of Health, but by the Israeli Digital Health Initiative, which is a very big initiative to turn Israel into a very digital country. So what we have to do is we have to accurately predict costs to different institutions using small vendors, not only what we decided to do on the major vendor. We have to allocate funds equitably to meet the need of different institutions that have different sizes and different affiliations. And we have to budget it in a manner that will create an incentive to proceed in a timely fashion. So our solutions were, of course, financial planning and financial incentive models that allocate the resources according to progression. So if you already have a team, you get 10% of the funds. And then if you already, worked out a work plan, so you're going to get another 10%. And then when you implement it halfway, you get another 50% of the money. So we're giving out the money, but we're giving it out first of all, according to need, big hospitals, little hospitals, and we're also doing it according to progression. And yes, with money, there's always an element of prayer, lottery, Our next challenge is professional capabilities. So, even though we're trying to minimize the amount of alteration to the EMR, there are some changes that are inevitable. And one of them is accommodating the longer fields needed for the SNOMED CT code, which is a lot longer than the ICD-9 code. So computer systems in each organization, the computer staff and their capabilities, they differ according to each institution. So if we give them, this task, we don't know how capable they will be to do this. And there's also a problem with informatics and medical terminology professionals that we need to implement this big initiative. And we don't really have so many people that are so fluent in medical terminology. So our solution has been to work closely with other people, other contractors that can help us. And we've been working closely with Clinical Architectures, which is a company that is going to be maintaining the terminology manager. And they're helping us with other needs other than managing the terminology, something like mapping and authoring and helping us. We're also recruiting highly qualified staff that we could, as much as we can get for the NRC. And we have to ensure the support for the terminology manager, which is called SNOMED, should be 24/7, should have service because it's going to be serving the whole country. Our next challenge is risk management. So patient level historical data has to be preserved and maintained and continue to be used, and has to be available to physicians at point of care. So that's a very important and critical part of our plan. Also, decision support systems that are crucial for patient safety, they have to be identified and modified to work with SNOMED CT. Now, because these systems may differ between organizations, this process has to be tailored to each organization. It's not something that we can control. So when we don't control, we're also kind of worried. And the visualization on the EMR screen and the presentation on the discharge summary has to be complete in order to ensure full information transfer to other providers and to prevent harm. And again, the SNOMED terms are a lot longer than the ICD terms. So we have to make sure that they don't get cut off like in the middle, which is something that happens. Also, automated billing systems that are dependent on the procedure and the diagnosis have to be updated to make sure that we don't lose any money. What are our solutions? Well, we're going to preserve historical data as is in ICD-9. We're going to present it to clinicians on the screen in every visit, but we're going to require recording of new diagnoses and procedures in SNOMED going forward. We're going to provide institutions with a SNOMED map to ICD-9. So every SNOMED term is going to have a map to an ICD-9 code in the format that's required in order to maintain existing decision support systems and administrative interfaces. And these automatic maps are going to be audited and maintained at a national level by the NRC. So now that you have heard our challenges and our proposed solution, I'm going to show you the diagram and we can take a closer look. So you'll see that we have our SNOMED CT catalog that's going to be on the terminology server, SNOMED, as well as an external search engine. Individual EMRs will connect with SNOMED terminology manager through UIs. Clinicians will work as usual in their local EMR, but this will reach out via UI to the SNOMED manager and return the diagnosis or the procedure term that will be recorded in the patient file and in the database. Constructing the implementation in this way allows everyone to use the same catalog, get the same result in their search, have the same mapping to ICD. Computer systems will need adjustment to allow the longer field for the SNOMED codes that are much longer than the ICD-9 codes. But in this way, they won't have to disrupt other core structures in their EMR. Institutions will implement this server in their own locations and have full control of their data. The distribution and updates will be managed by the NRC and transferred to the institutions. Each SNOMED term will have an ICD-9 code that's mapped to it, and the map codes will be transferred to the administrative database after being audited by the medical coder. Additional secondary use of data, which could be decision support, research, analytics, reports, documents, will be able to utilize either the SNOMED term or the ICD-9 term as chosen and defined by each institution. So we believe that in this fashion, we will be able to allow SNOMED CT implementation without disrupting too many work processes and the flow of data in order to allow better documentation by using SNOMED CT, but allow the continuity of administrative and other IT functions that can be later be upgraded to accommodate anyone else's needs or future innovation. So I was going to end there, but then I met Charles Guttridge from the NHS here. And after talking to him, I realized that there's another challenge that we had. So we started planning this initiative in 2018, 2019. We visited the NHS and to learn from them how they implemented SNOMED in the UK. And we came back with big plans and big dreams. And then when we sat down to start to work, we saw how complex this project was. And slowly we regressed and we restructured and we downsized our dreams. So, and then came COVID. And that took over our lives and put everything on hold. So basically, one of our bigger challenges, the challenge of the project leaders, was to overcome the down that we had experienced and to get back to the fast track and become industrious once again. So, so that's it. That's our initiative in a nutshell. And thank you very much.
Thank you. Yael will now take questions. As a reminder, if anybody would like to ask a question, please use the microphone in the room.
That's good. It means I was clear.
Okay. I have a question. Do you intend to translate SNOMED CT into Hebrew?
No, we do not intend to do that. The Israeli system is that we write in Hebrew, but the medical diagnosis or procedure is always written in English. So physicians will write in Hebrew the patient's history and everything, but when they document in the field of diagnosis, it'll always be in English. So we have no intention right now of translating. There might be innovation later on using for patients' purpose, maybe to have a patient-friendly translation, but that's next step, not now.
All right. Thank you very much. Thank you. With that, we will conclude the session. Thank you, Yael. Online delegates, you can join another session through entering the lobby.